Management of familial Mediterranean fever, FMF. Familial Mediterranean fever, FMF, is a hereditary inflammatory disorder primarily affecting populations from the Mediterranean region. It is characterized by recurrent episodes of fever, abdominal pain, chest pain, arthritis, and skin rashes. Effective management is essential to reduce the frequency and severity of attacks and prevent complications like amyloidosis. 1. Colchicine therapy, primary treatment. Colchicine remains the cornerstone of FMF treatment. It reduces the frequency and severity of attacks and prevents amyloidosis. Dosage. Typical doses range from zero point 0.5 to 2.0 milligrams per day, adjusted based on response and tolerance. Regular monitoring for side effects is necessary. Compliance. Patient adherence to colchicine is crucial for effective management. Noncompliance can lead to recurrent attacks and increased risk of amyloidosis. Anti-IL-1 therapy for colchicine-resistant or intolerant patients. Biologic agents targeting interleukin-1 IL-1 are used, such as anakinra, Kineret, a recombinant IL-1 receptor antagonist administered daily via subcutaneous injection. Canakinumab, Ilaris, a monoclonal antibody targeting IL-1 BAPE given as a subcutaneous injection every 4 to 8 weeks. Rilonacept, Arcalyst, a soluble decoy receptor that binds IL-1, administered weekly. These agents are effective in reducing inflammation and preventing attacks in patients who do not respond to colchicine. And 3, monitoring and preventing complications. Regular follow-up. Monitoring renal function and proteinuria is essential to detect and prevent amyloidosis. Serum amyloid A, regular measurement of SAA levels, can help assess the inflammatory activity and effectiveness of treatment. Kidney biopsy. In patients with proteinuria, a kidney biopsy may be indicated to evaluate the presence and extent of amyloidosis. 4. Supportive care and lifestyle modifications. Hydration and diet. Encouraging adequate hydration and a balanced diet to support overall health. Education and counseling. Educating patients and families about the disease, its hereditary nature, and the importance of adherence to treatment. Genetic counseling may be beneficial for affected families. Pain management. Use of NSAIDs or acetaminophen for pain relief during attacks, while avoiding long-term use due to potential side effects. 5. Research and emerging therapies. Ongoing research into new therapeutic targets and treatments continues to evolve. Patients may consider participating in clinical trials for access to cutting-edge therapies. 6. Psychological support. Chronic illness can impact mental health. Providing psychological support and addressing issues such as anxiety and depression is important for overall well-being. Conclusion. Effective management of FMF involves a combination of pharmacological therapy, regular monitoring, lifestyle adjustments, and patient education. Adherence to colchicine therapy remains fundamental, while IL-1 inhibitors offer alternatives for those with colchicine resistance or intolerance. Regular follow-up and monitoring are critical to prevent complications, particularly amyloidosis. In the management of familial Mediterranean fever, FMF, if biologic drugs are not available, conventional disease-modifying anti-rheumatic drugs, DMARDs, can be considered, although their role is more limited compared to their effectiveness in other inflammatory conditions. Here are some conventional DMARDs that have been explored for FMF management. Methotrexate. Mechanism. Methotrexate is an immunosuppressant that inhibits dihydrofolate reductase, leading to anti-inflammatory effects. Usage. There have been some reports of methotrexate being used in colchicine-resistant FMF patients with mixed results. It may help reduce the frequency and severity of attacks in some cases. 2. Azathioprine. Mechanism. Azathioprine is an immunosuppressant that interferes with purine synthesis, thus affecting the proliferation of cells, particularly leukocytes. Usage. Azathioprine has been used in some FMF patients with varying degrees of success. It might help in reducing inflammation and the frequency of attacks in patients who are unresponsive to colchicine. MUT3. Cyclosporin. Mechanism. Cyclosporin inhibits calcineurin, thereby reducing the activity of T cells and subsequent inflammatory responses. Usage. Cyclosporin has shown some effectiveness in reducing inflammatory episodes in certain FMF patients, though its use is limited due to potential side effects, including nephrotoxicity. 4. Thalidomide. Mechanism. Thalidomide has anti-inflammatory properties by inhibiting TNF-alpha. Usage. There are limited studies on thalidomide for FMF, but it may be considered in refractory cases. It requires careful monitoring due to its significant side effect profile. Considerations and monitoring, effectiveness, and safety. The use of conventional DMARDs in FMF is less well established than in other rheumatic diseases. Their effectiveness can be variable, and they often come with significant side effects that require careful monitoring. Regular monitoring. Patients on DMARDs should be regularly monitored for potential side effects, including liver function tests, renal function tests, and complete blood counts. Combination therapy. Sometimes, DMARDs may be used in combination with colchicine to enhance effectiveness. The combination approach needs to be individualized based on patient response and tolerance. Supportive care and symptomatic management. In the absence of biologics and with limited options for DMARDs, acetaminophen to manage pain during attacks. Lifestyle adjustments, encouraging a healthy diet, hydration, and stress management techniques. Patient education. Educating patients on the importance of adhering to prescribed treatments and monitoring for signs of complications. Conclusion. While conventional DMARDs can be considered in the management of FMF when biologics are unavailable, their use is often limited by variable effectiveness and potential side effects. Colchicine remains the primary treatment, and in cases of resistance or intolerance, careful consideration of the risk-benefit profile of DMARDs is essential. Regular monitoring and a comprehensive approach to patient care are crucial in managing this chronic condition.